Hello, my name is Lyubov Minyalenko. I work at the Department of General Practice Family Medicine of Zaporozhye State Medical University. Today, our topic is the principle of family doctors managing of somatic pathology during pregnancy. The frequency of extragenital pathology in pregnant women, according to various authors, is 30–70% and has no tendency to decrease. On the background of extragenital pathology, obstetric pathology is very common. Therefore, knowledge about the features of the course and the conduct of pregnancy and childbirth in women with extragenital pathology is necessary for the doctor of any specialty. Family doctors' responsibility in this case include to timely appoint and conduct a comprehensive examination of pregnant women with various diseases, to predict rejection of the course of pregnancy and childbirth in women with extragenital pathology, possible complications, their effect on the condition of the fetus, and more importantly, on the health and life of the mother. Promptly detect contraindications to pregnancy in women with extragenital pathology. Deontologically, tactfully, reasonably explain to a pregnant woman with extragenital diseases about the necessity of timely examination of her and the woman's consultation, and if necessary, in specialized departments in the Department of Extragenital Pathology of Pregnant Women. Deontologically and reasonably persuade a pregnant woman with a severe extragenital illness in the need for abortion to be discontinued on indications in any period of pregnancy. There are some critical periods during a pregnancy which include, in the case of cardiovascular disease and respiratory diseases, it is 28–32 weeks of pregnancy, the period of maximum hemodynamic loading and the most severe conditions for the function of external respiration and pulmonary circulation. In the case of hypertonic disease is 22 or 26 weeks, the period of frequent development of severe combined gystosis, the appearance of hypertensive crisis, and the development of the fetus. In the case of liver and kidney diseases, it is also 22nd and 26th weeks of pregnancy, when the maximum load of these organs occurs, the functional state of more often disturbed, the condition of the pregnant woman worsens. Later, gystosis joins. And finally, in the case of diabetes mellitus and other endocrine diseases, it is the period from 20 to 24 weeks of pregnancy due to the need to adjust the dose of insulin or other hormonal drugs, which is due in this period to frequent development of decompensation of this disease and fetal malformation. Most often in pregnant women, there are such diseases of the cardiovascular system as rheumatism and rheumatic heart disease, congenital heart disease, operated heart, hypertension, hypertensive conditions, myocardial disease. On the background of heart failure, few obstetric complications like late gystosis, miscarriage, bleeding, postpartum, purulent septic complication develop much more often, 2–3 times often. Rheumatism and rheumatic heart disease are found in 6 or 10 of pregnant women. They account for more than 80% of all diseases of the cardiovascular system in pregnant women. Doctors must take into account not only the form of voice, but also the stage of its development, the phase, the degree of activity of the rheumatic process, the severity of blood circulation shortages, the state of pulmonary and coronary circulation, the contractile capacity of the myocardium, the presence and severity of arrhythmia, thromboembolism, and other complications in the history, accompanying diseases and complications of pregnancy. Decompensation is more often observed among women over 35 years of age. Most often in pregnant women there are such rheumatic heart defects like mitral valve insufficiency, combined heart failure with predominant stenosis of the left atrioventricle, aortal defect of the heart, aortomitral heart disease, insufficiency of the tricuspid heart valve. Indications for abortion during acquired rheumatic heart defects are primary or repeated endocarditis, mitral stenosis of the second and higher stages, inadequately mitral valve third stage and above, combined mitral defects, aortic defects of second and third degrees. Many valve heart defects are mitral aortic, mitral tricuspid, mitral aortic tricuspid malformations, rheumatic carditis with coronary insufficiency. Indications for urgent hospitalization of pregnant women with acquired heart defects. The appearance of increased shortness of breath, tachycardia, pain in the region of the heart. Development of growth of decompensation, aggravated rheumatic process, the appearance of arrhythmia, thromboembolic complications, hemoptysis, HCG signs of coronary artery disease, violations of indications characterizing central or regional hemodynamics, contractile ability of the myocardium. Congenital heart defects account of 0.5 till 10% of all heart diseases in pregnant women. Among all congenital heart defects account for only 15 form defects which live to women of childbearing age. Congenital heart defects during which pregnancy can be conveyed are operated open arterial duct, isolated stenosis of the pulmonary artery with a slight narrowing passing without significant load on the right heart departments, first stage aorta coarctation, low defect in the muscular part of the intraventricular septum, and insignificant isolated defect between the atrial partition. The high risk of miscarriage is caused by expression of pulmonary artery stenosis, significant defect in the atrial fibrillation, coarctation of the aorta of second, third stages, wounds of the heart are blue type, syndrome of Eisenberg and Tetrad-Fallot. Pregnancy is contraindicated in a high level of intraventricular membrane defects. Surgical treatment of acquired and congenital heart defects. So it is better to spend it before pregnancy. The optimal term for cardiac surgery is 20-24 weeks of pregnancy. Obligatory anti-recurrent Betaline therapy in parents with acquired heart defects in the post-operative period. So there are some causes of increased blood pressure in pregnant women, and they are essential hypertension as a manifestation of late pregnancy preeclampsia and symptomatic hypertension like renal, endocrine, or hemodynamic. In the first trimester, it's just 33% of pregnant women have arterial pressure is reduced and the impression or relative well-being develops. However, in the future, arterial pressure is steadily rising, which leads to an increased risk of maternal and parental morbidity and mortality. So here you can see a classification of atrial hypertension in pregnant women. The classification includes chronic hypertension, gestational hypertension like transitory and chronic, preeclampsia and eclampsia that can be easy, moderate, and hard type, eclampsia, combined preeclampsia, and some situations where hypertension is unspecified. Chronic hypertension is hypertension that was observed before pregnancy. Gestational hypertension, hypertension that occurs after 20 weeks of pregnancy and is not accompanied by proteinuria up to delivery. Preeclampsia is hypertension that occurs after 20 weeks of pregnancy in combination with proteinuria. Combined preeclampsia is the appearance of proteinuria after 20 weeks of gestation with a background of chronic hypertension. Transient gestational hypertension is the normalization of blood pressure in a woman who has suffered gestational hypertension for 12 weeks and after delivery. Chronic gestational hypertension is hypertension that occurs after 20 weeks of gestation and persists after 12 weeks postpartum. When hypertension is unspecified, hypertension detects after 20 weeks of gestation in the absence of information on blood pressure up to 20 weeks of gestation. There are some contraindications to pregnancy on a background of hypertension, and they are arterial hypertriglyceridemia of 3rd degrees and malignant course, hypertensive disease of the 3rd stage, renal and renovascular hypertension, neurogenic hypertension, arterial hypertension for the endocrine genesis like Cone disease, pheochromocytoma, Ytsenko-Cushingoid disease, and etc. Treatment of hypertension in pregnant women. Pregnant women with mild to moderate primary hypertension who received continuous antihypertensive therapy before pregnancy, medical treatment after the diagnosis of pregnancy is cancelled. Patients with severe hypertension, vasorenal hypertension, Cushing's syndrome, nodular periarteritis, systemic scleroderma, diabetes mellitus, and severe lesions of target organs continue to have permanent antihypertensive therapy during pregnancy. If before pregnancy the treatment was performed by ACE inhibitor or angiotensin receptor blocker or by a diuretic, the patient is transferred to another drug, the use of which is safe for the fetus. Treatment of hypertension in pregnant women. An indication for the appointment of permanent antihypertensive therapy during pregnancy in patients with a chronic hypertension is diastolic pressure above 100. If chronic hypertension is characterized by an increase in predominantly systolic blood pressure, isolated systolic atherosclerotic hemodynamic due to insufficient aortic valve or open arterial duct, the indication for antihypertensive therapy is the level above 150. The purpose of antihypertensive therapy during pregnancy is the steady maintenance of diastolic blood pressure on the level 80 till 90. In pregnant women with hypertension, which is characterized by a predominant increase in systolic blood pressure, the aim of treatment is to stabilize the latter at level 120-140, not lower than 110. Non-medicated methods for the treatment of pregnant women with a chronic hypertension include peaceful mode, rational nutrition, psychotherapy, therapeutic physical education on testimony. Not recommended: restriction of consumption of kitchen salt and liquid, reduction excess body weight before completing pregnancy, and acute physical activity. So when we're talking about medical treatment of hypertension in pregnant women, the drug for the choice of antihypertensive therapy in pregnancy is metil-dopa due to proven safety for the fetus, including and in the first trimester. Labetalol has significant advantages over the other beta blockers due to the presence of alpha-blocking properties. Nifedipine may adversely affect the condition of the fetus in the case of intravenosus or sublingual use or high doses. The appointment of diuretics is possible only in patients with hypertension and heart failure or renal disease. Categorically contraindicated pregnant use of ACE inhibitors and angiotensin II receptor blockers. Magnesium sulfate is used for stratification of severe preeclampsia or for the prevention and treatment of convulsive seizures. When we're talking about monitoring of the pregnancy status, an overview of the measurement of blood pressure in the first half of pregnancy once every 3 weeks, from 20 till 28 weeks, and once every 2 weeks after 20 weeks, weekly. Definition of daily proteinuria for the first visit, from 20 to 28 weeks, once every 2 weeks, after 28 weeks, weekly. Daily safe monitoring of blood pressure in the home with the written fixation of the results. Ocular review with the ophthalmoscopy at the first visit to a woman's consultation at 28 and 36 weeks of gestation. If necessary, an examination for the fundus can be performed and more often and in the other terms, determined by a stratification of a preeclampsia risk. The ACG should be performed on the first visit at 26-30 weeks and after 36 weeks of gestation. Biochemical blood tests like total protein, urea, creatinine, glucose, potassium, sodium, fibrinogen, fibrin, prothrombin index should be measured for the first visit and after 36 weeks of gestation. In the second study, further determine the concentration of bilirubin and ALT and AST. Indications for urgent hospitalization of pregnant women with hypertension are increased blood pressure compared to baseline before pregnancy, joining preeclampsia, the emergency of hypertensive crisis, the appearance of projection of changes in the fundus, symptoms of cerebrovascular or coronary circulation, deterioration of the functional state of the kidneys. Arterial hypertension occurs in 11–30% of pregnant women and is characterized by a decrease in blood pressure above 160 and below. In 50% of cases, arterial hypertension occurs during pregnancy, and only 25% of patients report the physiological course of the labor and childbirth. There are no contraindications to prolonging pregnancy on the background of arterial hypertension. The treatment at the first step include the mode of work and rest, emotional and physical peace, therapeutic physical education, full nutrition. The second step are tonic drugs, eukinetic variant of the circulatory system, and Chinese lemongrass, eleuterococcus, a similar scheme. Respiratory diseases do not interfere with the fertilization and occur in pregnant women with the same frequency as in non-pregnant reproductive age. Most often in pregnant women are following disease of the respiratory system: bronchitis, pneumonia, pleuritis, bronchial asthma, bronchiectasis, and so on. There are general contraindications to pregnancy in the case of respiratory disease. It is respiratory insufficiency, pulmonary heart failure, purulent inflammatory diseases, diffuse pneumosclerosis, the presence of amyloidosis, diseases of the respiratory organs in the presence of which the pregnancy is contraindicated, bronchial asthma and stage 1 severe course, bronchial asthma, chronic pneumonia, bronchiectatic illness, woolly disease of lungs, emphysema of lungs, disorders of the respiratory organs in the presence of respiratory insufficiency or purulent inflammatory process, exudative pleuritis, hypoplasia of the lungs due to kyphosis or kyphoscoliosis. In case of pregnancy with a respiratory pathology, when bronchitis does not affect the course of pregnancy, the pregnant woman suffering from bronchitis should be hospitalized to the obstetric department of the maternity hospital. A pregnant woman suffering from cerebral pneumonia should immediately be admitted to the observatory. Childbirth is carried out in the position of pregnant half-bearing under constant supervision of a general condition of the patient. Pregnant with a pleuritis should be hospitalized to the observation office. Complicates the course of the disease, especially in the case of exudative pleuritis. In the case of bronchial asthma, as a rule, pregnancy is not interrupted prescribed treatment with the basic drugs. The reasons to emergency hospitalization of pregnant with the diseases of the respiratory system are the emergency or increased respiratory failure, development of cardiopulmonary insufficiency, attacks of bronchial asthma, acute inflammatory disease of the respiratory system, urinary tract disease and pregnancy. Kidney diseases in pregnant women are common. Pyelonephritis is about 6-7%, glomerulonephritis 0.1-0.2%, and urinary stone disease up to 0.35%, and constitute a serious threat to normal development of gestational process in fetus, as the pathology of these organs lead to a breakdown of vital functions of the body, and the pregnancy significantly increase the burden of the kidneys. The attention is drawn to a wide range of diseases in children which are based on the disorganization of the urinary system, that is, the disease of the urinary system of the mother is an etiological factor. Pregnancy and kidney diseases. When directing on the admission of pregnancy in women with a kidney disease should be taken into account the nature of the course of the disease and the state of the bottom of the eye, the presence and the severity of hypotensive syndrome, and the presence of a renal failure. There are contraindications to pregnancy during kidney disease, like renal insufficiency, symptomatic arterial hypertension, acute glomerulonephritis, subacute malignant glomerulonephritis, chronic glomerulonephritis, pyelonephritis of a single kidney, chronic pyelonephritis with frequent excebrations, purulent pyelonephritis and pyelonephrosis, hydronephrosis of a single kidney, bilateral hydronephrosis, urolithiasis with frequent seizures of the renal colic, tuberculosis of the kidney, amyloidosis of the kidney, polycystic ovary, abnormalities of kidney development which are accompanied by prudent inflammatory process. Indication for urgent hospitalization of a pregnant woman with the diseases of the urinary system are acute inflammatory diseases of the kidneys, the appearance of progression of renal failure, increased blood pressure, presence of urinary syndrome, like increased proteinuria, hematuria, and cylindruria, the appearance of progression of changes in the fundus, and stroke of the renal colic. The number of patients with the pathology of the glands of the internal secretion is constantly increasing, which is associated with urbanization and deterioration of the economic situation in our country. Pregnancy is an extremely heavy burden for the body of a patient with diabetes, which requires a physician's knowledge of the features of pregnancy, childbirth, and care of the newborn. The presence of various forms of thyroid pathology in turn affects the outcome and prognosis of pregnancy. The formation and development of the fetus increases the risk of non-pregnancy, stillbirth, delayed fetal growth, and significantly increases the incidence of birth defects. Application of modern methods of treatment of adrenal disease contributes to the restoration of impaired reproductive functions and reduction of severe complications of pregnancy in this contingent of patients. Here you can see a classification of diabetes mellitus in pregnant women. There are prehistoric diabetes, type 1 and type 2, also gestational diabetes. In the group of prehepatic diabetes, patients with type 1 diabetes predominate, with 80% of the cases being pregnant with childhood and adolescent diabetes and 5% with adult diabetes. The most adverse obstetric prognoses are for child diabetes. The disease arose between the age of 14. Contraindications to prolonging pregnancy in diabetes mellitus are severe forms of vascular lesions, the level of glucose and glucose hemoglobin at the early pregnancy more than 10%, insulin-resistant diabetes, pre-coma in the first trimester in pregnancy, sugar diabetes in spouses, a combination of diabetes with a sensitization or pulmonary tuberculosis, the presence in the history of cases of stillbirth or development defects of the fetus despite the full compensation of diabetes through the gestational period. Indications for urgent hospitalization in diabetes mellitus. Increased glycemia up to 9.0 mol na liter and above. The compensation of diabetes mellitus. Progression of vascular complications. The appearance of signs of renal failure. The emergence of complications of pregnancy. The emergence of signs of formation of diabetic fetopathy and first discovered during pregnancy diabetes. Contraindications for prolongation of pregnancy in case of thyroid diseases are acute thyroiditis, autoimmune thyroiditis Hashimoto, medium and severe thyrotoxicosis, diffuse goiter, 4th and 5th stage. Hypothyroidism is a severe form of stage decompensation. When deciding the question of the admission of pregnancy in patients with a pathology of the hepatobiliary system, it is necessary to take into account the nature of the disease, the process activity, the functional state of the liver and the hemostatic system, presence of hepatic insufficiency, presence of portal hypertension. Also, the presence of varicose veins of the esophagus and the stomach. So there are contraindications to pregnancy, such as hepatitis, acute infectional toxic allergic, chronic active hepatitis, cirrhosis of the liver, all forms, cholestasis and cholangitis, calculosis cholecystitis with frequent attacks of the liver colic, purulent cholecystocholangitis, cholangitis accompanied by jaundice or high fever. Contraindications for prolongation of pregnancy with a pathology of the digestive system are exacerbation of peptic ulcer and duodenal ulcer, gastrointestinal bleeding of ulcerative etiology, exacerbation of pancreatitis, violation of the functions of the pancreas, nonspecific ulcerative colitis. There are indications for urgent hospitalization in the pathology of the digestive system, like deterioration of condition, appearance of pain, dyspeptic pneumonia phenomenon, violation of the function state of the pancreas, stomach, acute pancreatitis, aggravation of chronic gastroduodenitis. The diseases of the blood system and pregnancy. As you know, the most common clinical form of the pathology of blood during pregnancy is anemia. Pregnant anemias are divided into two main groups: anemia that arose during pregnancy or as a result of pregnancy, hypochromic or iron deficiency anemia, and hyperchromic or pernicious megaloblastic anemia. Anemia that existed before pregnancy, aplastic or hypoplastic anemia, hemolytic anemia, autoimmune hemolytic anemia, anemia associated with a violation of globin products. Contraindications to pregnancy are hemolytic anemia, aplastic and hypoplastic anemia, leukosis, lymphogranulomatosis, myelogenous disease, idiopathic thromboidiopathic purpura, disaggregation thrombocytopathy with a hemorrhagic syndrome, hemorrhagic diseases with frequent exacerbations. Thank you very much for your attention.